Very good morning to everybody and welcome to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds today. Today is a special day because this is also a part of our George P. Noon conference under the J.C. Walter Jr. Transplant Center, and we have a special guest today, and I want to welcome all of our Grand Rounds attendees and also alert them that there's a whole day of activity going on in the George P. Noon conference that they can register and log on for the rest of the day. I also want to welcome all the attendees of the George P. Noon conference who are live stream watching this. I want to also inform everybody that as through the Grand Rounds, you can definitely ask questions through the pollev.com site or entering DeBakey, or you can use text. You'll have the information on the screen. With no further ado, today we have a special guest, and Dr. Mann is no stranger to Houston and our institution, and I jumped at the honor of introducing him, except I knew Dr. Guillermo Torre, who's here with me, was probably going to do a better job. And for many who know Dr. Torre, he's, for a lack of a better word, I call him the godfather of our program, a phenomenal gentleman, my mentor and friend. And for those of you who know him, yes, he's still a part of our institution, and no, he's not the president of Mexico yet. And with that, I will transition over to Dr. Torre to introduce Dr. Mann.
Arvind, thank you very much. It's really a great pleasure to be here today. First, because the transplant program has had a tremendous impact in the Houston area, and it's all under the influence of people like Dr. DeBakey, Dr. Noon, and also because of Dr. Mann's work and presence. And I'm going to take a couple of minutes just to share with you a little bit of his background that certainly needs no introduction for all of us that have studied and lived heart failure for many, many years. But Doug finished medicine from Temple, did cardiology fellowship at the University of San Diego, but more importantly came over to Houston many, many years ago. And at that time I was, Arvind, I was actually in medicine, and Doug came over to the VA to join the faculty at Baylor College of Medicine and the great program that we had at that time. And I had an interest in doing research. I had done research for many, many years in immunology, and you know, this is going back almost 30 years, and Doug, I think, was one of the very few individuals in cardiology that had an interest in inflammation and immunology. And I had a brief conversation with him. I was pursuing my research years, and his passion for research was infectious, more infectious than COVID today. And that led me to work with him for many years, and I have the honor to be one of the very first research fellows that worked with him, and I was so happy, and that has marked my career for many years. But I think I shared that with you and with the audience because I think that's been perhaps the signature for Doug's career through the years. I think that one of the things that he enjoys the most is to mentor people, to help them proceed in his or their path in career, and many of us that are here today have enjoyed that from him. He's published over 300 papers. He's been member of the editorial board of many different journals. He recently received the Lifetime Achievement Award for the Heart Failure Society of America, has grants, continuous grants for many years, and I think more recently has also dedicated a lot of his time to be the editor of the JAG Basic Translational Journal, which really exemplifies everything that he has done and what he wants to do the next very successful part of his career. And I said that because recently stepped down from the job of Chief of Cardiology at Washington University to continue his career in basic and translation research. So Doug, I am very happy that you're joining us today, and you will continue to be, for me and many others, an example in life, career, and your passion to pursue research and medicine has been an example to all of us. Thank you for sharing with us this next 45 minutes on what's been the passion of your life and many of us. Thank you.
Yeah. So I want to begin by thanking Arvind and Guillermo for inviting me to speak. I wish I could be there in person today. We live in these incredibly strange times. And I also want to thank Guillermo for the generous introduction. I think I learned more from him than he from me. But it's been phenomenal, the relationships that one has with trainees, many of whom were in the medical center. So I'm going to try to begin my talk today by sharing the screen. That worked. And then the next thing is to see if the slides will advance. So the topic I was given today is heart failure is a progressive disease. How to keep patients from slipping the stages. Is recovery the answer? And when I saw the title, I said, well, recovery is really always the answer. So I'm going to briefly talk about this concept of heart failure with a recovered EF, which is really an interesting journey for me as a heart failure biologist. Pardon my voice. So we know that heart failure begins after an initial index event causes a decline in pumping capacity of the heart, and the heart undergoes a process known as left ventricular remodeling. Over the last 30 or so years, we've become really good at implementing a number of medical and device therapies. This in turn will lead to a recovery of left ventricular function. This recovery can be complete with the EF greater than 50%. It can also be partial with a recovery greater than 40%. And then there are a group of patients in whom there's really no functional recovery. And these are the patients that go on to advanced heart failure and transplant. The topic of my talk today will really be this group of patients here who I think even as early as 5 years ago, we would have claimed victory and thought that we'd cured them of their heart failure. And as it turns out, this group of patients really has an interesting biology that's distinct, but they continue to develop heart failure for reasons that are unclear. So I was fortunate enough to be part of an expert panel commissioned by Dr. Fuster, where we really tried to drill into this group of patients because there are no practice guidelines for this group of patients because there really are no data. So the panel suggested that we use the nomenclature heart failure recovered EF. The R for me stands for reduced, implying that the patients at one point had low ejection fractions and had remodeling. The working definition that we proposed, and again, this is not in practice guidelines, we hope it gets into them, but there would be a documented LVEF less than 40%, that the ejection fraction increase greater than 10%. In the literature, there are also cutoffs of 5. We thought this was beyond the range of inter-observer variability. If there should be a second measurement of left ventricular ejection fraction at least 3 to 6 months out from this baseline recovery to get away from hemodynamic changes or diuretic-induced changes. And we think that really assessing the left ventricular ejection fraction is key. So what about the epidemiology of these patients with recovered left ventricular ejection fraction? This slide just shows the epidemiology of a group of patients with recovered left ventricular ejection fraction. Turns out there's some great examples in nature of patients who will get transient LV dysfunction and then recover completely. They can be grouped really into 3 separate groups: toxic insults, inflammation, which is what Guillermo and I have studied for 30 years now, and then this other class of abnormal energetics. The best example of this probably is tachycardia-induced cardiomyopathy. The other group of patients with toxic insults today, it's probably most likely chemotherapy. We know that a number of the drugs that we use to treat patients with advanced cancers will drop EF. If the medicines are stopped, the ejection fraction comes back. And then we know also that a certain percentage of peripartum patients, and then even patients with myocarditis, will recover their left ventricular ejection fraction. So many years ago, I tortured Mike Gevertz into doing this exhaustive summary of the literature with me. And what we did was to go through every paper at that time that had been published on the group of patients that I just discussed. And we looked at 2 things. What was their final ejection fraction after they recovered? Did they completely normalize? And did they improve by at least 10%? So this would be a modern day definition of heart failure with recovered EF. If you look on the back bars here, these are the people who improved their ejection fraction by more than 10%. I have an error bar here for chemotherapy because depending on the chemotherapy, the ranges are different. But you can see here that most forms of spontaneous recovery of ejection fraction, at least 50, more likely 80%, do recover EF by more than 10%. However, if you look at the front bar, the orange bars here, not all of them normalize their left ventricular structure and function. So the energetic groups are the most likely. Again, here the hit to the heart is the least. And if one then goes and looks at viral myocarditis or postpartum or another group of patients with recent onset cardiomyopathy, you can see here the ejection fraction really doesn't normalize in the great majority of patients. This is a slide from the Brown-Wells Companion to Heart Disease, which I edit. And this just shows that every single FDA-approved therapy that we have for treating heart failure, there's some degree of reverse remodeling, whether it's ACE inhibitors, beta blockers, CRT, or left ventricular assist devices, or CRT. All of these devices in part work by causing reverse remodeling. So what about the durability of these responses? So after the ejection fraction improves, most of us would consider that it's game over, that we've done our job, and the patient should be, in essence, cured, or at least not have recurrent heart failure. Turns out that's not the case. So I want to briefly summarize some data that came from the WashU Heart Failure Registry. When I moved from the medical center to St. Louis, the NIH was giving out dollars. This was the era of the 2008-2009 financial collapse. So the NIH, basically, you could write any grant you wanted, and they were giving money as part of the stimulus plan. So we set up a registry, and I was agnostic in the registry about what the ejection fraction was. I said, just go collect as many patients as you can and then do 2-year follow-up. So we were able to enroll about 1,100 patients. The majority had heart failure reduced EF. Some had heart failure preserved. And then there was a resident who was interested in getting a letter for fellowship. So I asked Ashish, I said, why don't you just go look in this group of people who are mid-range EF? And this is at a time before it became a popular subject. And I said, figure out which of these patients had a reduced ejection fraction before they came in the registry, which had preserved ejection fraction, and which were in the middle. And as you can see here, this group of mid-range EF people, most of them had heart failure reduced EF, got better on medical therapy, and then we did longitudinal follow-up on these patients. So this is event-free survival. So we looked at death, transplant, or cardiac hospitalizations, and we had pretty good follow-up for 2 years. You can see that the mid-range EF people do better than reduced EF. And this is probably a no-brainer for the heart failure mafia. These are responders to medical therapy, so of course they're going to do better than non-responders. The more interesting part of the data to me was if you look at the same events and then compare it to heart failure preserved EF, these are age and gender matched patients, you can see that they have about the same heart failure events. So although the fact that they've had partial recovery of function and they're on guideline-directed medical therapy, they still continue to have heart failure events. So we've now taken this question one step further, and what we did was we did a large-scale proteomic study on these same patients I just showed you, and this was just published in JACC. And there's some really interesting findings I want to share with you this morning. So first of all, we had a group of patients in our heart failure registry. As I said, some had reduced, some had preserved, some had mid-range. We stratified them by their left ventricular ejection fractions, as I showed you previously. We had blood draws on all these patients at baseline, and then we used an Aptar-based proteomics analysis, and I'll explain this on the next slide. So we just did a large-scale proteomic survey, about 1,100 proteins on each of these people, and then we did some bioinformatic analysis. So the way in which the SomaLogic scan works is they've designed a number of DNA aptamers. So this is DNA that will bind to specific proteins. They then modify the aptamers so they can be bound to a variety of different substrates and then released. The bottom line is that this will allow you to simultaneously measure 1,100 proteins in one group. The downside is that it doesn't give you a level of a protein like we're used to reading in labs, but it does allow you to compare levels of proteins between groups. So I'm going to show you comparisons of these SomaScan in HFrEF, HFpEF, and heart failure mid-range. If there are no differences between the groups, the comparator the bar will look gray. If, on the other hand, there are increases in protein, they'll be shown as red, and there are decreases in protein levels between groups, they'll be shown in blue. So the first thing we did was to compare HFrEF versus HFpEF, and you can see there's a fair amount of red and blue here, indicating that there are a lot of differences between these two groups of heart failure patients. Not a surprise to those of us who care for these patients, they respond to medicines completely differently. If, on the other hand, you look at heart failure mid-range EF versus heart failure preserved, and remember, they have the same kind of heart failure events, you can see there's a lot more gray. So at least at the proteomic level, these patients look more similar than HFrEF and HFpEF. And then more striking, perhaps, if you compare HFrEF, and remember, the majority of these people heart failure mid-range EF, heart failure reduced, there are a lot of differences. And this group of people largely came from heart failure reduced EF. So this concept is really illustrated better in these so-called PCA plots, which allows you to group the data very simply by their first principle variance. So if you look at the HFrEF, it's shown by this cloud here. HFpEF is shown by this cloud here. And then the heart failure mid-range EF is really distinctly different. So they're different profile, but overlapping heart failure preserved EF. And then what we did was to split this group out into the ones that actually recovered their EF and the ones that didn't recover their EF. And probably not surprisingly, the not recovered are between HFpEF and HFrEF. But again, this heart failure mid-range EF group that improved is distinctly different, at least at the proteomic level. And again, I've argued for years that these patients still have heart failure, right? And you can see that the heart failure proteome overlaps other heart failure proteomes. So again, the concept is they're distinct, but they have several features that are very similar to heart failure. Okay, what about the epidemiology of people who completely recover their EF? These are patients that Arvind and Guillermo would say, we've done a great job here. They've completely reversed remodeled. Ejection fractions are completely improved. There's a paper by Bazare. Jim Fang was the senior author. They used a very similar database to the one that we had developed at WashU. It came from Penn. And what they did was to look at people with a reduced EF, they're shown in purple, patients with a recovered EF, so they were reduced, completely recovered, they're shown in green, and then there's the heart failure preserved EF. So if one looks at probability of death, transplant, or VAD, the reduced EFs that don't recover have the worst outcome, not surprising, and the ones who recover on medical therapy do much better from a death and heart failure standpoint. Again, these are responders to guideline-directed medical therapy. This is a no-brainer. More striking to us was the fact that the heart failure events, they're coming in with recurrent heart failure, looks a lot like heart failure preserved EF. So this looked almost identical to our data that we've seen in the heart failure mid-range. So again, although they completely recover their ejection fractions, they still have recurrent heart failure events. So another paper by Merlo and colleagues in Italy, and they have a very nice group of patients with dilated cardiomyopathy that's exquisitely phenotyped with MRI. They went into their database to find a group of patients who had completely recovered their EF on guideline medical therapy. Only 15% of their cohort met this definition, and then they followed them longitudinally. The interesting thing was, of these people, and no heart failure doc would argue that they had normal left ventricular structure and function, about 40% of these people developed recurrent heart failure events when followed over time. So most recently, a paper by Lupon, and this group is from Spain. They also followed serially left ventricular ejection fraction, showed that the non-ischemics initially will recover, but then deteriorate. And also, not surprising, the ischemics recover a little bit more, but not as much as the dilated. But again, shown here, there's this U-shaped curve that characterizes patients, even though they're on adequate medical therapy. So the question then becomes, what's going on here? So a number of years ago, I was at a Gordon conference, and I was with Dan Burkhoff, and this is when the LVAD mafia was claiming that all these patients were recovering, and then they would come back in the hospital in a couple months. And so I asked Dan, I said, do you think recovery exists? And he said, I don't know. So together we worked on this sort of construct of remission and recovery. But we asked the question is, what's different about the ventricle? These are the same size ventricle, but what's different about this ventricle than this ventricle? Are there differences in the cardiac myocytes, the myocardium, or the left ventricular geometry that would allow you to predict who these patients are? So, at the time, we didn't know what to call this. So I wanted to be able to call patients who truly recovered and never needed to see a doctor again. That to me would be recovery. And then we coined this term remission. Dr. Frazier insists that I stole this from him. I don't know where it came from, but the concept, I think, that these patients remain asymptomatic but are likely to develop heart failure is the thing that I think remission captures. So the question is why? So at the end of the day, I'm a heart failure biologist, and I want to walk you through some of the reasons why I think this occurs and then make some recommendations for doctors. So this is my sort of construct for understanding how the ventricle works. I look at changes in myocytes, changes in the myocardium, and changes in geometry. The first thing is that despite the fact that the heart gets smaller and may contract better, the transcriptional profile in these hearts never goes back to normal. And this was actually known by Ken Margulies a number of years ago. So this is patients with dilated cardiomyopathy, had LVADs at WashU, and then we did RNA-seq on these patients. Again, I'm just going to focus your attention on these PCA plots. These are the dilated cardiomyopathy signatures. These are the non-failing, and you can see that people that are supported by LVADs, all of these patients had reverse remodeling and the ventricles got smaller. Their gene profile is somewhere in between. So again, they're not normal, but they get closer to normal. A really interesting study. So if you just go through and look at which components of the myocyte recover, you can see here, these are reverse genes, not a lot of activity there. These are the persistently dysfunctional genes, the ones that stay abnormal. Only the sarcomeric genes are the ones that reverse remodel here. And that probably explains in part why contractility returns. And again, just summarized here, you can see that for virtually all aspects of the myocyte, matrix, integrin, metabolism, EC coupling, they remain persistently dysregulated. But however, the sarcomere does improve. Another really interesting study by Armbedecker out in Colorado, what they did was to take myocytes from non-failing hearts, failing hearts pre-VAD, and then myocytes from the same patient post-VAD. They take the myocytes, isolate them, suspend them between two tweezers that can measure the tension. They strip the sarcolemma off the cell, add calcium, and they can generate like these force curves. So you can see non-failing, fairly good, 15 millinewtons of force. Failing, not surprisingly, the myocytes are depressed. And then post-LVAD, they improve significantly. However, they're still significantly depressed when compared to non-failing. So again, the idea is the myocytes are better, but they are not normal. Now, what about myocardial alterations? If one goes and looks at the matrix, there are a number of changes that occur in the matrix, and Guillermo, I know, has done work on this. After VAD, there's a reversal of the matrix abnormalities, and part of that is driven by the medical therapies. But there are still some underlying abnormalities of collagen, and no one's really looked at the 3D weave. We've been good about quantifying the amount, but now not how it's organized. So the matrix is not completely normal, although it moves more towards normal. I think one of the more interesting things was the geometry, which I had always assumed normalizes, really doesn't completely. This is a study from a colleague of Dan Burkhoff's. What they did was to take human hearts at the time of transplant and do pressure volume curves on them. So they must have had a cardiology fellow who could carry buckets and buckets of buffer to perfuse these hearts. But what they do is show that the pressure volume curve, normal patients here, the LVAD support is shown in dark line. So the pressure volume curves are completely normalized. These are the pressure volume outcome. However, what they showed in the paper is that although the dimensions normalize, the long axis and the short axis normalize, the R to H ratio does not normalize. So this is really a poor man's wall stress. So although the ventricles are smaller and the longitudinal and AP directions, they don't normalize their wall stress. The wall thickness never comes back to normal. So now you have a myocyte that has an abnormal transcriptional profile, does not contract completely normally. The matrix that it's embedded in is not completely normal, and the ventricle can't normalize wall stress. So it's perhaps not surprising that these hearts, when they're stressed, will redevelop heart failure. So this is a statement that took probably 10 years for me to figure out at least, but reverse remodeling is not simply a mirror image of the molecular and cellular patterns that become dysregulated during forward remodeling, but rather reverse remodeling represents a coordinated multi-level process that allows the heart to adopt a new but less pathologic steady state that's associated with improved pump function and improved clinical prognosis, no doubt. However, many of the multi-level molecular changes that occur during forward remodeling remain dysregulated in reverse remodeling hearts, despite improvements in structure and function. So although they look normal to us as clinicians, they still remember or they have elements of a heart failure biology. And I think this is one of the reasons why these hearts continue to fail. So I've got a graphic, if I can advance my slide. Yeah, so this sort of summarizes what I think happens is you have a normal ventricle, there's remodeling, and with reverse remodeling, this ventricle comes close to, but never comes back to a normal. And the amount of heart failure biology that's retained in here, I think, would predict how fast these hearts will relapse when they're stressed again. So I want to try to put this together in a clinical construct that will be useful for today's symposium. And so Arvin asked me to sort of, how do we keep people in recovery and from relapsing? What are the clinicians supposed to do? You're at a crossroad. The first thing I can tell you is what not to do. And again, limited information here. There are the results of the TREAD-HF study. This was a phased withdrawal of pharmacologic treatment for heart failure. How they got this passed in IRB, what they did was to look at people who had recovered their ejection fraction. They used a very stringent diagnosis or definition of recovery, including normalization of the ventricular size and a reduction in NT-proBNP withdrawal of guideline-directed medical therapy. Their primary endpoint for relapse was a decrease in EF by greater than 10%, increase in volume by greater than 10%, or twofold rise in NT-proBNP. The study was stopped prematurely. Within 6 months, 40% of people that we would have considered cured ended up redeveloping heart failure when the medical therapy was taken away. The primary reason was a reduction in ejection fraction. The secondary reason was the volumes were dilating. And I was pleased in the discussion, and I didn't review this paper and ask them to put this in, but they said, this finding suggests that for many patients, improvement in cardiac function following treatment does not reflect full and sustained recovery, but rather reflects remission, which requires at least some treatment to be maintained. So again, as part of this expert consensus panel, we tried to come up with some guidelines. Again, they're really not evidence-based, so I'm just throwing them out, open for discussion, about how clinicians should follow these patients. Again, this is a group of people on a telephone trying to come up with something useful. It's not evidence-based for the most part. So the first thing is to understand who's more likely to undergo reverse remodeling and recovery of ejection fraction. As I showed you before, non-ischemic etiology predicts it. Lower duration